Thanks very much. I'm looking forward to everybody's comments. So what I'm doing now is writing a textbook that compares the health insurance systems in a number of high-income countries. And last spring, I was spending some time here on sabbatical from UCLA at the Schaefer Center. And Rebecca asked I'd be interested in presenting some of my preliminary work with regard to equity, and that's what I'll be doing today. So I want to start off with just a bunch of caveats about what you'll be seeing here. First of all, it's early in the project. The book is due in 13 months, and I have no reason to think that it's going to be on time anyway. So keep that in mind, please. And the focus here, of course, is on equity, not on efficiency. The larger project is comparing health insurance with regard to all aspects, well, not all aspects, but many aspects. But here I'll be focusing just on equity. So it's important to understand this is really a partial analysis. I'll be focusing just on financing, not on delivery. That's where my expertise would be. I don't look at long-term care at all. Long-term care in almost all the countries is very local, hard to get information about them if they're not English-speaking countries, and really would be a separate project in itself. The analysis is qualitative. I'll be talking about that a lot today. It's all numbers, so it's certainly empirical, but I don't try to do any econometric work. I'm going to try to show you why I chose not to go down that path. And finally, it's based entirely on secondary sources. I visited these countries, but I haven't visited them professionally. And I'm hoping, if this project works out, maybe do a second book that's more prescriptive rather than descriptive, that would involve visiting the countries and learning more about them while there, inspired by a book by 10 years ago by T.R. Reid, a Washington Post journalist, called The Healing of America, where he not only visited the countries, wrote about them, he's a great writer, but in addition to that, he had a chronically aching shoulder. So he actually went into the healthcare system to try to see what they would do to try to fix his shoulder. It's a really neat book, and I would recommend that people take a look at it if they're interested in comparative systems. Every country faces challenges in paying for healthcare. And I guess the thesis here is that these challenges are going to lead to equity problems, and the way in which a country organizes its healthcare system has the ability to help ameliorate some of these problems or actually aggravate some of these problems. So the purpose of the study is to see if there's some relationship between objective measures of equity and health system characteristics in a number of high-income countries, each of which has dealt with these problems in their own unique way. And I'll focus on high-income countries because that's what I think the lessons are for the U.S. There are lots of challenges, a couple fundamental ones. One is the causal link between equity and health insurance system. I mean, so many other things cause outcomes, SES, and health behaviors and preferences. So I'm going to have to try to find equity measures where one can make an argument that the healthcare system is largely responsible for differences that we see in equity. And so one thing I'm going to be doing is focusing some on equity of access, which I think can make a stronger case. Things like life expectancy, infant mortality, which is something that Alice, our discussant, has done some really interesting work on. Those things largely are not determined by the healthcare system. So I think we have to be really careful here to make these judgments. The other thing is that I have a really small sample size. I have 9 countries, as you'll see, and I only look at them now, so I don't have longitude. And so it's a small sample size, and it's really hard to categorize them. Countries have morphed over, their systems have morphed over time. And what you see is that they're not either or, they're a mixture of this and that and almost every characteristic. And you can try to quantify these as independent variables, but I don't think it's very successful. And I'm going to give you an example of that right now. So people have tried to quantify health system characteristics related to outcomes, do econometric studies. And I'm going to show you a slide or two now that shows you an example of that and why I have not gone down this path. So the study I use is a recent one from Giannino and BMC Health Services Research last year, and it's based on another study in health policy by Bowman colleagues. What they do is they look at 22 European countries and they end up classifying them in 3 ways: regulation, financing, and provision. And each is a dummy variable: state versus societal for the first 2, or state versus private for the other. What they do is they collect amenable mortality rates. I'll talk about that measure a little bit later, between 2001 and 2014. And they regress these on these 3 dummy variables, and they interact with years and years squared. And they conclude that only one variable, which is provision, mattered. The countries that have private as opposed to state provision did less well in terms of improvement in amenable mortality. So are these results believable? Well, I don't think they are. And this is, again, why I haven't gone down that route. First, you wonder if these are the right-hand side variables. I mean, you could divide a healthcare system this way. You could also look at private versus public provision of services. You could choice of hospitals, choice of doctors. You could look at whether it's a national base versus geographic base. There's a lot of different ways you could organize a healthcare system in order to set up the variables. And I don't know if this is necessarily the most effective one. I think that, as I mentioned before, the zeros and one assignment is really arbitrary. It's unconvincing. It moves nuances. I'll give you some examples. Like the Netherlands was called state regulated. But more than any other country in Europe, it has a system of managed competition with providers competing, with insurers competing for the business of getting patients and negotiating with providers. And to me, it doesn't seem really the idea of a state-financed, state-regulated at all. Switzerland would be another example with regard to financing. Switzerland is said to be societal financing, but there are tremendous, large federal infusions of money to help the health insurance funds that get an adverse selection. So I wasn't convinced about those. And then the other thing is very different countries are being combined. I mean, you have to believe, if you're going to be doing it this way, that the coefficient is going to be the same for each of the countries that are given a 1 versus a 0. And give you an example, a couple examples. I mean, do we really think that societal regulation of government, if a state regulation in France means the same as state regulation in Poland, or if private provision in Netherlands means the same thing as private provision in Hungary? I don't think so. So anyway, that's sort of a long-winded way of saying why I haven't gone this direction. I have nine countries. Oh, by the way, I'm not really going to go into any previous research. There isn't time. The most interesting previous research related to me, I will allude to later, by the work of Wagstaff, Van Doorslayer, and colleagues about 20 years ago for the World Bank, where they looked at all of these concepts of healthcare equity. I don't think, though, that there's been a comparable effort to do what I'm trying to do in looking at the literature, which is to try to relate the health equity measures with the health system characteristics. So I have 9 countries, and my criteria, I had several criteria. One is that they had to be interesting places. These are countries that people talk about their healthcare systems. The second is I needed data on equity. And all of these countries are part of one of the data sets I use, which is from the Commonwealth Fund. I'll talk about it in a moment. But I needed those because they were the best data source with regard to healthcare equity. In my larger study, I also looked at Japan, but they're not in the Commonwealth survey, so I couldn't include them for you today. They also include Norway and New Zealand, but I had various reasons that I didn't include those. Basically, I wanted an even 10 countries, and with these and Japan, I had 10 countries for the larger project. So what's interesting about these countries? Because I'm going to be talking about findings in each of these. Australia. So Australia is really interesting to me because it's the only country that strongly encourages people to buy private health insurance. They're viewed as a single payer system, but the government gives financial carrots and sticks to try to supplement it, presumably to protect government monies. Canada. Well, I like to study Canada because people on the left point to Canada as this, really great healthcare system and something that we should emulate. And you may or may not agree with that. One interesting thing that I found in this study is that Canada does actually pretty miserably with regard to healthcare equity compared to a lot of the other countries here. It's also different than one of my other countries, England, because it's done at the provincial level rather than the national level, and provision is private rather than state-run. So it is a unique system. France has a number of interesting features. One is a hybrid between the England-style system and the social insurance type systems in Germany and the Netherlands and Switzerland. And so I find that interesting. People have a choice of health insurers or sickness funds, but people don't have much of a choice of health insurers and sickness funds there. And government has a pretty big role. France, those of you old enough might remember, it came out as #1, the best system in the entire world of 191 countries in a World Health Organization study in the year 2000, much maligned by the research community, but France was #1. It has the lowest amenable mortality rate in the world. It also has really low out-of-pocket costs, and that's interesting because we're going to see really big equity issues in France, which surprised me quite a bit. Germany, as you know, had the first social health insurance system, went back to the late 1800s. But unlike France, government plays a very small role. It really is societally done. It's done by consortia of providers negotiating with consortia of insurers. The other thing about Germany that's really interesting is they allow a certain number of people to opt out of the mandatory health insurance system, 11%. I'll be talking that off and on about that today. The Dutch system is super interesting because it's like the American system on steroids. They use an Eindhoven-style managed competition system, but even more so, they have way better risk adjustment than, say, our large employers have. Their system looks very much like the exchanges under the ACA, but it's done under a system of universal coverage. And you're going to see the Dutch do the best of any country in equity in terms of the measures that I have. They have an individual mandate that's really enforced, and they have low out-of-pocket spending. So it's like the US, but it's different than the US. And also, there are subjective studies that are done of health insurance systems in Europe, and Netherlands and Switzerland usually top the charts as the best healthcare systems in Europe by some of these subjective measures. Sweden I wanted to use because it's like the UK and been kind of a government-run system, but it's done at the local level, the county level, rather than the national level. It's had some problems with waiting lists, but it certainly has an ethic of equity. Switzerland is touted for its really great healthcare system. They have the highest out-of-pocket cost of any high-income country. And so I'm going to be really interested in seeing if that has an implication for equity. And spoiler alert, it absolutely does. And finally, the UK, well, not finally, the UK is the prototypical national health system. They're heavily invested in equity, but in addition to that, they've certainly had their challenges with regard to waiting lists and so on. They're also the country that really has bought into using cost-effectiveness analysis to decide what services are going to be covered by the national health system. But ultimately, my interest is in the US, since it's my country. We're exceptional in so many ways. We lack universal coverage. There's a lot of underinsurance. There's the international rankings are horrible with regard to things like life expectancy, infant mortality, a host of other measures. But we have some certain virtues. We have unparalleled organizational innovation, I think. And also we look really good in some measures, like particular measures of cancer care. So anyway, that's a lot about why I've chosen the countries I have. So let me talk about my variables and data. There's not a lot of agreement on how to measure equity. The bins I like to put them in is equity of access, equity of utilization, equity of outcomes. I don't really like to use, well, in this project, I didn't like to want to use equity of utilization because I think that utilization is so affected by health status and by preferences. I think we do better by looking at equity of access and equity of outcomes. Particularly equity of access, as I said, I think is, you can tell a stronger story related to the healthcare system. So when I look at equity of outcomes, I focus on measures where I really think I can make a case that it's the healthcare system that's causing the problems. So I have 4 data sets here. The Commonwealth Fund, what they do a survey every year, but every 3rd year it's a survey of adults. So they have a sample between about 1,000, 2,000 people, each of 11 countries, and they ask them a bunch of stuff. And luckily for me, they divide some of this by income, so I'll be using that. I also have data from the OECD, from the World Bank, and from the Eurostat. I'll be showing you those variables in a minute. The Eurostat variables are only for 6 of my 9 countries. They're the ones that are European. So all told, I have 21 variables, 10 access, 11 outcome related. Most of the time I'm comparing those lower SES to those higher SES, but there are, I think, 5 measures where I just have a population measure. So these are my measures. I hope you can see them. So these are the equity measures. I'm sorry, the access measures. You can see going to the right, it's pretty recent data. The Commonwealth Fund is always looking below versus average income, but I've also got some quintile data on income and highest versus lower education for some of the other ones. Anyway, so the variables are cost-related access problem last year. Everything is self-reported. Serious problems, unable to pay medical bills, skipping dental care checkups due to costs, unmet needs for dental exam by income and education, catastrophic spending is spending more than 10 or 25% of income, having regular source of care, difficulty getting after-hours care, and waiting 2 months or longer for a specialist. And for outcomes, the first 5 variables are for the population as a whole. So these are things that you figure that people who are not well off would be disadvantaged. So I'm looking at diabetes and asthma, both avoidable hospitalizations and deaths. I'll only show you slides on the top 2. And also mortality amenable to healthcare. It's a really popular measure these days. It's a controversial measure. It's defined as people dying before usually the age of 70 due to diseases that the healthcare system should have saved them from. But there's a lot of research showing that probably it isn't just that, it's probably SES that's also relating to it. So in the US, it just does terribly in the measures of medical mortality. But anyway, it's a measure that's popular, I wanted to use it. Then I look at self-rated health status by income and education. And then the last 4 measures are basically how people feel about the medical care they're getting, whether poor people feel that they're not getting good care as wealthier people. So I'm looking, rating the regular providers, fair or poor, doctors knowing important information about medical history or the bottom one, specialty care, and also doctors spending enough time with people. So let me move on now to my health system characteristics. And I divide these into 3 groups: social insurance, voluntary private insurance, and financing. Voluntary private insurance, VHI, is a concept that's a really big deal in all the other countries. It does not translate well in the US, as I'll explain. So my measures for healthcare system characteristics is, first of all, how much is spent, the 2 most common measures, who is covered, basically the uninsurance rate and whether it's government or compulsory coverage, what is covered. I look here just at dental care because all the other main stuff, except maybe in Canada, tends to be covered. The thing that is sometimes a little bit iffy is prescription drugs, and the provinces vary with regard to that. Generally, their prescriptions are covered in these countries, but dental care often isn't. So that's one of the things I look at. And then, how much is covered, deductibles, co-pays, co-insurance, that sort of thing. And who's exempted from those. So let me explain to you voluntary private health insurance. So this is what government or compulsory coverage pays for. Let's suppose somebody isn't covered. They're either uninsured or they buy health insurance, which is called substitutive health insurance, to be covered. That only happens, not counting the US, that only happens in Germany, where 11% of the population do that. Everyone else has the compulsory coverage. Now, what benefits are covered? Well, something isn't covered, you pay for it, or you can buy something called supplemental voluntary health insurance. And that covers things like dental care that might not be covered in the national program, but sometimes it also allows you to jump the queue or have more choice of specialists. Now, there always are co-payments it's for some services, some systems, so you have to pay cost sharing, or you can buy complementary voluntary health insurance. So these VHI programs in the countries, they're all very different from each other, and there's something that I happen to be really interested in. Finally, with regard to financing, this is the most complicated system characteristic, and I talked about a lot in the paper that Alice saw. It's I didn't find much of a correlation with equity, number 1. Number 2, I haven't studied it as much as I need to study it because, there's so many aspects to components of financing. Some are regressive, some are progressive, and it takes a lot of work to sift it out for each of the countries. So anyway, I'm going to be, let me just say one thing. The work of Wagstaff and Van Dorselaer found that in general, if government or compulsory schemes, like, sickness funds through work, pay for something, it's generally progressive, okay? Not all taxes are progressive, VATs are not progressive, but generally government compulsory is progressive. Out-of-pocket was always regressive. And voluntary health insurance varied, but in a place like Germany where people could opt out, it was regressive. So let me move on to the findings, which are divided into 3 parts. Differences in equity, differences in health system characteristics, and finally, what the paper's about relating the 2. So what I'm going to show you now are really quickly is 14 of the 21 equity charts, okay? So these are the dependent variables in a sense, better than quantitative analysis. Cost-related access access to medical care problem in the past year. So the blue bar is below average income, the orange bar is above average income. So we're looking at both magnitude and gap. Anyway, I'm going to go through these quickly. You'll see that the US has the biggest magnitude and the biggest gap. We also have a real problem in access in Switzerland, but also something of an access problem in Australia, Canada, and France. In general, we're going to find that Germany, Netherlands, and the UK had almost no access problems compared to the other countries. And Sweden really only had access problems with regard to dental care. Had serious problem, were unable to pay medical bills. The biggest problem and the shocking thing was France, where 41% of the lower income half of the population said they had a problem paying medical bills. So I'll be talking about that later. The US also had problems, so did Switzerland and Canada, and even the Netherlands had a little bit of a problem there. Skipping dental care because of costs. Biggest problems Australia, Canada, and France, and the US, also in Sweden and Switzerland. I think there are only 2 countries that covered dental care in their national system. I think it was Germany and the UK. This just looks at unmet needs for the European countries. We see them in France, Sweden, and Switzerland. We don't see them in Germany, Netherlands, or the UK. That was just, I also had that by education. Catastrophic spending. This was really surprising to me. I thought the US would be worse, but actually more catastrophic spending reported in Switzerland, in Australia, and Canada than in the US. This would be interesting challenge. Some people advocating single payer systems, I think. Exact same pattern here. Biggest problems, though, in Switzerland, again, because they have such high out-of-pocket costs, which you'll see in a moment. Have a regular doctor, place of care by income. The US is really the outlier here. A lot of people didn't have a regular doctor, and there's a big gap by income. Not a big surprise, knowing the US system. Waiting 2 or 4 months. This is one of the more bizarre slides. We do see a pro-rich bias in one country. There's waiting 2 more months for specialist appointment. Australia had a pro-rich bias. But look at, and Canada had really long waiting lists, but it's for everybody. UK, the wealthy were twice as likely to complain it happened to them than the less wealthy. And France, the same pattern. So that's, that I cannot explain to you, but I don't have to because I'm trying to look at the opposite pattern, which is like what's going on in Australia. So now I'm going to show you quickly the outcome slides. I just have 3 of them to show you. Diabetes, the US does poorly in most of these. Actually, Germany had more avoidable hospital admissions for diabetes, US second, France third. US by far the worst with regard to asthma avoidable hospitalizations. And US by far the worst with regard to amenable mortality. 20 years ago, actually, the US wasn't the worst. It's the other countries' amenable mortality has gone down a lot faster than our amenable mortality has gone down. So, self-assessed health status, pretty much. Healthier people are wealthier people. A little bit bigger gap in Germany, but otherwise, no surprises there. So this the last I think 3 I got here is how people feel about their system. Well, the lower income people in France are really pissed. And if you've looked at the news the last 2 weeks, it seems to be highly correlated. I do not think that we've got any coincidence going on there, but I'm not a political scientist. There's also the Swedes rated their pair poorly, but there wasn't too much of an income differential. A pretty big income differential in the United States. Especially lacking medical history, regular doctor not being informed. Biggest problems in the US, Canada, and Australia. So I'm going to quickly summarize what I learned here. And it's pretty straightforward. Australia's got a lot of access problems with a lot of equity problems. Cost, skipping dental care, catastrophic spending. They were unique in poorer people having bigger waits to get services. Canada had the exact same, almost the exact same access problems that Australia did, but the waiting time was just bad for everybody, basically. France had surprising cost-related access problems. The country that by far had the biggest problem paying bills, and I'll be able to explain that, skipping dental care, and remember the French were pissed about the quality of the care of the poor French. Germany did really good in regard to equity. They did have the high avoidable hospitalization for diabetes, that was it. Netherlands was kind of like the big winner, and I don't know if I've ever really been a managed competition buff my whole career, but it seems to be working out pretty well in the Netherlands with regard to equity, which of course is one of the great fears with regard to managed competition. Sweden did pretty well, but it has some problems with dental care because it's not well covered. Switzerland had, after the US, the biggest access problems, pretty much problems with everything access related, the biggest catastrophic spending by far, problems by far, but did well with regard to outcomes. The UK looked pretty great with regard to access disparities, but they had relatively high amenable mortalities. They have long waits, like in Canada, but it's kind of for everybody. In fact, it was worse for the wealthier people. The US, we pretty much have the kitchen sink. Okay. So, a couple other things here. So, now I want to show you the results with regard to the health system characteristics. And first, with regard to spending. Well, this is kind of interesting. The two countries that have really big access problems, the US and Switzerland, have the highest spending. So you could view it as one way. You could say as well, they're certainly not buying access with how much they're spending. Or you could say, well, gosh, they're spending so much they need high out-of-pocket costs. So, there's a couple different ways you could look at that. But with regard to spending, the US and Switzerland stand out. Coverage, everybody has universal coverage except the US. Germany is 11% of the people in the orange bar, they have the substitute coverage. The US has 9% uninsured now, it used to be 16%, and the orange bar is low because we just have Medicare and Medicaid as the compulsory coverage. I suppose we still have compulsory coverage sort of now for 3 more weeks until the mandate is no longer a mandate. So with regard to how much is covered, we have really high deductibles in the United States. I think that's part of what's going on. Switzerland has high cost sharing after deductible, 10% co-pays. Australia has some pretty high co-insurance. France has very high co-insurance, but almost everybody has voluntary health insurance to pay for it. With regard to drugs, there's 0 no co-pays in 3 countries, Netherlands, Germany, and the UK. They do very well in all the access measures. They're higher elsewhere. The Canadian provinces generally don't cover drugs, so you need voluntary health insurance. Only 2/3 of the people have it, and generally it's through employment, which is regressive. So Canada's got some real issues with regard to paying for drugs. Most countries do have protection mechanisms to avoid catastrophic spending. With regard to, I may have skipped one thing, but I'm not seeing it here. With regard to voluntary health insurance coverage, if you don't count Germany, because they have that different type of substantive coverage, it's not a very big deal in Germany, the UK, and Midland, and Sweden, Netherlands, Switzerland. The countries that rely on it the most are Australia, Canada, and France, and they're the ones that have some access problems, and I think that there's a regressive element going on here. Australia, as I said, it's strongly encouraged by the government, half the people own it. Canada, you get it through your employer. If you're not in the employment market, you can have problems. France, you need it. 95% of the population have it. Only the 10% poorest get it for free. In Germany, it's not just the wealthier people can opt out, it's also civil servants and self-employed, which I'll get back to. With regard to sources of funding, I want you to focus on out-of-pocket here. And look at Switzerland. 28% of spending is out-of-pocket. It's a real outlier compared to the other countries. Australia second. We saw access problems there. The US, why so low, 11%? Well, actually, US is the second highest country in per capita out-of-pocket. This 11% is being multiplied by enormous out-of-pocket per capita. So out-of-pocket costs are a big deal in the US, but the percentage is low, and it's actually been low for many decades. With regard to the Gini coefficients, I have before tax and after tax. And after tax Gini coefficient, the US is the least equally distributed income among the 9 countries. Yes?
Right. You would point out to these big differences between low income and high income in France, and given that 95% of people have voluntary health insurance, and that it's even free for like the 10% poorest, like, is there any data on the income gradient and like how much people are actually paying out of pocket, or is this non-financial costs? Like, I mean, typical out of pocket costs, like costs of taking off work or something else?
So I'm gonna try to answer that question in a couple slides, okay? Because I think that's the most interesting result of all here, but I think it has to do with a weirdness in France that I'll tell you about. So actually, we're gonna be getting that in the next slide. But anyway, so putting it all together, I'm at the end here. So relating equity to health system characteristics. Well, before I do that, let me just say one thing. It's a tale of two countries, the Netherlands and the US. We have very similar healthcare systems. They had almost no access equity problems. We had tons of equity problems. What's different? Well, the Netherlands has a history of solidarity. It has universal coverage. It enforces the mandate that it has. You can't jump the queue there like you can in other countries. You have supplemental insurance that doesn't get you to get services quicker. They have much lower cost sharing than we have, and they have a much better, they have a much more equal Gini coefficient. It's a matter of opinion whether that's better or worse, depends on where you stand. And so here are two countries that look very different in some ways, but look very similar in some ways, but there are reasons to expect different equity results. And so what are the main, main thing I'm able to come up with in this, exploratory, correlational, preliminary analysis is, first of all, universal coverage matters. The other countries have it, the US doesn't. High cost sharing matters. Switzerland, the US, Australia had the highest out-of-pocket cost per capita, and they had a lot of problems with regard to costs. I sort of had a typo there, and the US did not have the highest catastrophic spending, but Switzerland and Australia did have higher. Benefits package matters, particularly with regard to drugs and dental. Germany and the UK covered both pretty thoroughly. They have the fewest equity problems. The biggest gaps are Australia, Canada, Sweden, and the US. They have the highest equity problems. So what's in your package matters. And I think it matters in part because VHI, in my mind, is somewhat regressive. Australia, Canada, France, and to some extent Sweden had some access problems, and they also relied a lot on VHI. It's unevenly distributed among the population, is much of the problem. The other part of the problem is a lot of countries you can jump the queue. The wealthier people can do better by having a VHI. And I didn't point this out to you, I meant to, but if you look at out-of-pocket spending, the countries that we think of as single-payer countries have relatively high out-of-pocket spending. And it's understandable. When you have to pay for things out of tax revenue rather than out of wages, it makes sense that you need to cut back, and you're going to have to have, you're going to have to rely more on out-of-pocket costs than on VHI. Other findings. One was that Germany really didn't have much of a problem. So it doesn't appear to have two-tier medicine, even though these 11% of people opt out. I think that's partly because it's not just the rich people opting out. The other is it's only 11%. And it just isn't enough to have really a nasty two-tier type of system. So France, getting back to the question. So France had strange results. A quarter of the lower half of the income distribution cost-related access problems, 41% had problem paying bills, 34% skipped dental care, 10-fold differences in unreported dental need by income, surprisingly high catastrophic spending, and the largest differential in the rating of the quality of medical providers. France does have the lowest per capita out-of-pocket costs of any of the countries, okay? So what is going on here? Well, I think the main thing going on is a very bizarre thing about the French healthcare system. In France, you pay your bills directly, and then you have to go to the insurance company to be reimbursed. This can cause real liquidity problems for people. So why do they do it this way? Well, every time they try to change it, the doctors go on strike. The doctors like being paid directly. They don't want to be paid by insurers. And as much as policy people have wanted to change that in France, they have not been able to change that in France. There are a couple other things going on here, a few other things going on. There's balanced billing in France, and that can hurt the poor people more. The cost sharing there is in primary care, but there isn't that much cost sharing for the reason that you mentioned, that almost 95% of people have VHI, but 5% don't, so that's part of what's going on. But another part of it is those with the free VHI might not be getting the same care. It's almost like a Medicaid type thing, which is that these people, the doctors are not allowed to balance bill them, and maybe they don't have the same access. But I also think that part of what's going on is a social class schism that we see brewing in France, but that's just my hack political science there. Final slides. More spending doesn't buy more equity. US and Switzerland have the highest spending overall and out of pocket, but overall, and most equity problems. The UK had low spending, few equity problems. I'm not going to try to say that the reverse is the case, but anyway. So by way of conclusion, I have said enough, so I'll let Alice take it from here. Thank you.
All right, so thank the organizers for the opportunity to discuss and the privilege of reading this paper. It's one of those papers where it feels like every page you're reading, you're learning something new. And in particular, there's just a lot of information here, and so that was fun to go through. You know, this, if it wasn't obvious already, this is a ridiculously hard question to answer, it's essentially like thinking about the causal link between health equity and health insurance systems. Ranges from difficult to impossible. So I think the best that we could do is think about the plausible links, which is where I think Tom has made some progress here. There's a lot of challenges, many of which Tom had mentioned. To start with, just identifying what is health equity and what is identifying health insurance systems in and of itself are difficult measures to come up with. Then there's a data problem, limited comparable data, and then there's changes over time that you have to track limited data and changing metrics, and all of that just sort of becomes a complicated mess. So in that sense, I think Tom has done a great job in trying to get some clarity on what can we actually say and what do we actually know. And so I find the health equity metrics, both the access and the utilization variables, to be fairly believable, and I like the way in which the health systems were defined in terms of thinking about social insurance, thinking about voluntary insurance, and thinking about financing, which I actually thought was one of the more interesting, my personal preference, the more interesting part of this paper. Because Tom didn't have a chance to go through this, I get the opportunity to actually think about, well, what actually has been done in this area. There is a lot of work looking at international comparisons between health spending and health, right? So like actual levels have been discussed a lot. In particular, there's the March 2018 paper, Papanopoulos and JAMA, did I think a pretty good job of this, thinking about what are the relationships between spending and utilization, and talks about things like, well, the US tends to have higher prices, more so than higher utilization, and we have a sicker population, more rural populations, and we have lower levels of insurance that affects access. But on this particular question, which is actually very different, which is looking at health inequality, not the levels, but really the differences in the levels, there is much less work. And I think we do have some information here, mainly looking at the relationship between health inequality and income inequality. I think that has been there's an interesting graph I'll show you in a minute that establishes that relationship. It turns out that health inequality is more associated with income inequality than really the underlying levels of income or expenditures or even social services that are provided by the government. And then there's some work also talking about out-of-pocket costs and the fact that how high out-of-pocket costs really affect the poor. But even this study on the bottom there is a US specific study and not an international comparison. So we really are limited in what we know internationally about inequality and health systems. I wanted to show you this graph because I think it establishes, the baseline of how I think about health inequality is its relationship to income inequality. And so this paper, 2015 paper by Jutz, looks at 42 European countries, and I think from here you can pretty clearly see that the greater the income inequality, the greater the health inequality. And I'll come back to this relationship at the end of my discussion because I think it's important to note that. One of the findings that I thought was fun is the one that you found at the end about how throwing money at the problem doesn't necessarily solve equity. So spending more is not really necessarily the solution for improving equity. And you can see this from, this is suggestive evidence from Bradley et al. And it turned out to be in her book too, of looking at how much spending, social spending is going on. And yes, the US spends a lot in health, but we make up for spending less in social services. So if you add the two categories together, social services and health expenditures, it turns out that the US is actually, not at the right tail of we spend a lot and don't get that much out of it. We just tend to spend less on social determinants of health, which is what this graph is showing. So I think that just sort of lays the background of where the literature is at and really where the paper's contribution is thinking about these health system characteristics and what about them might matter. So just to summarize, I think universal coverage, cost sharing, benefit packages, and reliance on private or voluntary health insurance, those seem to be important. And that's, I think, one of the main takeaways of the paper. I always like to think of things in relationship to the U.S. And so, I was surprised to see that the U.S. is bad, but not uniquely bad in some of these metrics. In particular, it seems like a lot of people have cost-related access problems. Dental care is almost always shafted. Sometimes the U.S. looks particularly bad, but it's not alone. And then again, there are these differences that people like to focus on, which makes it look like it really is the terrible place it is in terms of efficiency, if that's how you want to measure it. We have no mechanism to avoid catastrophic spending. Children are not exempt from cost sharing. And interestingly, I think we have a particularly high reliance on private insurance, which may be contributing to inequity through either ability to access it through cost mechanisms or through time access and jumping the queue. So where we could take this paper next, when I read it, I think there's a lot of really good information here. I think what would help to synthesize some of this information is perhaps access to better data, and this might turn into a different paper of sorts, but thinking about really access to the US data that we have, there's a lot of within US variation in which I think some of these questions can be explored in a more detailed way. In particular, if you think about US geographic variation, I think the one that comes to everyone's minds is the map of the US and how there's different expenditures in different regions of the US. But if you think about it internationally as well, the US actually also has particularly high geographic variation in spending relative to UK and Canada, and this is looking at the coefficient of variation of spending. And so in that sense, I think trying to explore within US variation can be interesting, geographic variation in particular. And so some things that I think would be nice to learn about is how does the Gini coefficient in healthcare financing differ across regions in the US? Do certain regions look more similar to other high income countries? And specifically, do some of the conclusions about the role of health insurance line up with health inequity that we see within sort of varying regions of the US? I think something else that would be interesting too is just coming back to this role of income inequality. So, I showed you that graph of the strong relationship. I think the question that's in my mind is, well, if income inequality makes that big of a difference, what role is there for health systems or health insurance structures? And so controlling for income inequality and then looking at what is remaining, I think and how much of health insurance explains the remaining health inequity would be really interesting. I thought it was a really great paper. Thanks.
Time for questions? You want to the questions? Or respond? Any responses to Charles's comments? No.
Let's open it up. Jeff.
Balance billing is permitted in France. There's no constraint on physicians and hospitals.
I don't know if there might be constraints in hospitals, but yeah, balance billing is, there's a tradition of it in France, is my understanding. I don't know specifically where it's prohibited, but I believe half of French say they've had at least one balance bill during the last year. So.
Any sense, do people know if I go to you, it's not going to cost me much. If I go to Jay, it's going to cost me a lot?
Yeah, well, yes. I mean, what I don't know about in France is how well that's known to people before they show up to you or to Jay. I think there are other countries that allow it, but France, the French doctors are steadfast in keeping their independence, as you can see by the direct payment.
Two comments. One is I think it's fascinating from a political economy standpoint that they want to sort of have direct payment. It might be constraining prices a lot. If you just look at the overall price levels, a pediatrician appointment in France, based on my own anecdotal experience, costs 25 euros, which is on the order of the copay that I pay in the US for a visit that costs $150. So it's this might be constraining their payments, which is sort of weird. But the other comment that I wanted to make is related to something you said, where sort of voluntary health insurance could be regressive, particularly as complementary type. And I guess I want to emphasize that I agree with that. I've written a few papers looking at voluntary health insurance, and one of them looking at the U.S. in the context of Medicare, where a lot of people buy supplemental insurance, and so it's actually more regressive than it might look on the face of it, in the sense that there's moral hazard that's generated by buying voluntary coverage. So in the context of the U.S. with Medicare, when people buy Medigap, I show that causally that seems to increase Medicare's expenditures,
Absolutely.
the public programs expenditures through moral hazard, on the order of about 20% per person who's buying it. So it could have sort of strong regressive tendencies to have those sorts of policies.
Yeah, absolutely. I mean, that's one of the things that not many people know, is that Medigap is subsidized by the taxpayers, what you're talking about in that paper.
A little bit related also to the point of moral hazard, another one of the surprising findings you were saying is that the UK in this group was the country that used cost-effectiveness analysis the most in making decisions, but had the highest mortality amenable to healthcare.
Well, second to the U.S., yeah.
Oh, okay.
Yeah.
Just that, I was wondering if you could comment on that puzzling finding. Do you think that we're not buying as much health as we thought we were? Or, I mean, especially with universal access, do you think people have less healthy health behaviors because they know they'll be covered or something like that?
Yeah, I'm one of these believers that the amenable mortality is not really capturing what we think it is. So they kind of throw up their hand. So it's defined as things you want to define, like asthma deaths. But then they throw in 50% of cardiovascular deaths. Why 50%? Well, it's between 0 and halfway between 0 and 100. So I think it's really arbitrary. They throw in all the preventable cancers, but there's such a heavy SES component there. So I think that probably why the U.S. and England the U.S. does so poorly, and England fairly poorly there, has more to do with the structure of societies. I don't really trust the measure very much.
Just wanted to point out that UK is not the only country that uses cost effectiveness. Netherlands uses it, Australia uses it. Almost every other developed country uses some form of cost effectiveness.
Yes, that is absolutely right. We are exceptional in that regard.
Kind of a side note, so some of your equity measures rely on somewhat like a subjective assessment of respondents, right? Your satisfaction, what a serious problem is. And at least in like subjective well-being research, it's been shown that there are systematic differences across countries on how people respond to this using vignettes and things like that. So I was wondering if you have any thoughts on. I know they're not. Some of your measures are less,
Yeah.
amenable for this than others. But I was just wondering.
So it was a 50-page paper, and I stuck in one line just for Alice, which is that I really am unsatisfied with my equity measures. I did not say it. Did you notice that line? I agree with you. I have all these measures, but I don't really think it's capturing the big concept. All the big concept. The vignette one is interesting. I would love if anybody knows of any other data that compare any of the stuff by SES and things that we can argue that the healthcare system matters. I'm really interested in finding it out. I just feel the concept is way richer than these self-assessed comparisons that I'm able to give. Yeah, so I completely agree.
It's a fascinating paper. But how would you think about the result? Would they be different if you thought about how the poor are treated in each country as opposed to equity measures? I mean, equity is like, I think, this social solidarity kind of idea versus the like generosity of Medicaid versus the systems that cover the poor in other countries.
It's a really interesting question. I mean, on the surface, the poor have the same type of coverage as the other people. So it may be that the way in which the poor are treated differently is their lack of access, say, to voluntary health insurance. That would be one example. I'm going to think about that one because that would be a nice way to be getting at some of this stuff. But we're really the only country that divides it up into categories. Who gets, like, there isn't senior coverage in any other country. Right. Everybody has coverage. So we're really in. Japan has separate healthcare. Sorry, I haven't thought about Japan since I started working on this paper. Yeah.
But what's interesting to me that all these countries also have social inequalities and health outcomes. So looking at the gradient of social inequalities and health outcome might give some suggestion of how well the system does in treating everybody.
Yeah, I mean, that's an interesting point that even.
And part of what, at least in Finland, what they have argued is that the better educated know how to demand for services in a way that those who have less schooling, for example, can. So that might be one matrix.
The idea of looking at social inequality, social gradients, irrespective of whether you feel good about those measures largely being affected by the healthcare system, is a really interesting idea. All these countries, there are decent data from Eurostat on differences in life expectancy by education, all these countries. And the gradient's actually, it's like a 5-year difference. I mean, it's pretty standard across the countries.
It's about half of ours.
Yeah,
What's
it's
that?
surprising.
About half of ours.
Yeah, half of that? Okay.
Half of ours.
Half of ours. Yeah. Yeah, I like that idea. Jen?
Quickly, related to Alice's comments, I've seen some statistics breaking up the best 5 states in the U.S. versus the worst 5 states. And so the Massachusetts, Minnesota, they look like a lot of European countries on many health metrics, and the Alabama, Mississippi look like Wakanda.
Yeah, and that's kind of what I'm taking out of Alice's main suggestion, or first suggestion. She can actually answer that question with regard to infant mortality because she studied that. But yes, Minnesota looks. If you look at our top 5 countries with regard to infant mortality, we look sort of not bad in Europe. Not the best, but not bad. But what I took out of her comment was that one could look at other aspects, other health system characteristics in the top 5, bottom 5 countries in the U.S. and they are very different. Although the 2 overwhelming ways they're different, well, I guess 3. One is uninsurance rate, one is Medicaid, and the other, I guess, would be rurality. But that would be an interesting way to extend the work. Yeah, I would. If Minnesota were a European country, I'd be very interested to see how it did on all of these measures. Yeah. Do you have anything to add on?
No, though I will say that I actually think your measures aren't as bad maybe as you think they are, mostly because they're within country comparisons between poor and rich, right?
Yeah.
And so you're comparing across countries, but really it's the gap within a country that you're looking at.
So can I confess something? So 3 days ago, I wrote to the Commonwealth Fund to say, hey, you're giving me this above average, below average income. Can you give it to me by quintile? They wrote back and said, well, no, we don't think so. because we asked people, is their income below average in the country? I promised this would be in the next draft of the paper. But then what the question then becomes is, did they tell people what the average was?
yes.
Or did they just say, do you feel below average? And I guess I would know that if I see the distribution, see if it's 50 or 50 or not. But that was one of those knife wounds in the heart.
It's
Yes.
tricky.
So Tom, do you know anything about the distribution of how good the care system is across countries? So, like within this country, we know it explains a lot of, say, the differences we get with racial outcomes are eliminated if you look at, for some things, what hospital people went to or where they were treated, because everybody who goes there gets bad care. So is France so Paris-centric, for instance, that it's good there and it's not good in these rural areas,
Yeah,
which
I
are
don't
now?
really know. I mean, there's certain countries that are advantaged, like the Netherlands, where
Well, yeah.
everybody in the Netherlands is near
Near
a really good
place.
facility.
Yeah.
But that isn't true in France and in England, where there are substantial rural areas. And because I don't know the answer
Yeah.
to the question in terms of how good the rural care is there. Just don't know. I mean, you can see this overall project of trying to understand each of these countries deeply is sort of a fool's errand. There's just too much to know.
But a necessary one.
And like in Japan,
I don't think it's a fool.
in Japan, there are enormous differences by geographic region, not in spending, but in use of services. So like, I mean, it's more than the US. But
Japan is just bizarre in every way, shape, or form. I
Well,
think they were just
I'm not-
lucky
actually, I'm
because
not sure
they're
that
very
that's-
healthy.
I don't know, I think there are a lot of geographic differences across all of these countries, especially
Yes.
the UK for sure, I bet. You find
There
this.
are, yeah.
Not in spending, but in use of services.
Yeah.
I mean, it's sort of an underexplored area, I think.
Yeah, it is. Yes.
Yeah, thanks. Well, two quick questions. One, maybe you answered that maybe you didn't look at a lot of deep elements, but one is around decentralization and health systems governance. Because from the UK, there were kind of decentralization reforms that happened fairly recently to like with NHS, to Manchester to make it more governed essentially from Manchester rather than nationally. So I was wondering if that came up in any of these analyses. I mean, and another maybe slightly bigger question is how you're thinking of, because you have the WHO cube and those three different dimensions of coverage, and there's kind of like the traditional frameworks of the Bismarck beverage systems, and whether, I think Joe Kutzen at WHO recently wrote, like, Beverage and Bismarck are dead, along with Beverage and Bismarck, some paper on this. So I was wondering if you think of these health system frameworks as useful as well?
Yeah, so the first question was about the
Governance and decentralization.
Yeah, I mean, it's easy to find out which countries are the ones that are decentralized, and the Scandinavian countries tend to be the really decentralized ones. And to be able to then ferret out what impact that has is hard. It's not something that I've tried to do. So for this book I'm writing, it's a textbook, and I'm trying to figure out, you don't want to have 10 countries just listed in a row, a chapter in each, you want to break them up. So I've been thinking a lot about the framework. And the Beveridge versus Bismarck thing, is somewhat passe right now. But I'm not finding a lot of good alternatives. In the papers I showed one of the earlier slides, I didn't find that very satisfactory. Where I am this week, because I actually talked about a European colleague with it this week, is I'm thinking of just dividing the countries into single payer versus multiple payer. And that works pretty well, except France has multiple payers, but it looks a lot like some of the single payers. But anytime you try to break it down further than that, you start getting all these counter examples. European systems have really converged a lot. So I don't think you can go very far with the traditional breakdowns. And I think that a lot of people in policy community in Europe are reaching the exact same conclusion. You just have to talk about features like decentralization. Yes?
So I know the effectiveness of preventative care is still...
Of what care?
The effectiveness of preventative care is
Yeah.
still doubtful for many,
Yeah.
but still I'll be curious to see, do you have any measures of access to preventative care or usage? Because I'll be curious to see if that shows up in the data as like a proxy to, early access to,
No.
to care or something like that?
You know, I'll do that, because I think it's a really good idea to see if I can get a measure of preventive spending. There are measures out there that it's more that, do you believe that these measures are really, what is preventive care, and do they really have a data system that is comparable across countries? But I'll look into that, because I would be interested in seeing that. You know, the general feeling, you know, in the School of Public Health, is the U.S. is a light spender on preventive care compared to the other countries. But I don't know if I could defend that at this stage. But I will look into that.
One other suggestion, like, have you thought about using the HRS like sister data sets for this? It seems like almost all of those countries, maybe not Australia, except for Australia, has an HRS like data set in it. It seems like
They're all
that there you'd have.
almost all in share and Elsa.
Yeah.
Almost one?
All in
Share.
share and
Share
Elsa.
and also,
Yeah.
yeah.
And
The
it's all,
European.
I've tried to do
harmonized,
this,
right?
I've tried to do this, comparing countries in share and Elsa, and I've given up because it's so complicated, so. You need
It would
to
be,
do it.
I mean, I am interested in getting aggregates, but I could certainly construct aggregates from that. Yeah, I
Yeah,
will.
And wouldn't they be available from the harmonized,
Yeah, harmonized, well,
The-
some things are available in the Gateway to Global Aging that Jim Cook runs here, Lee runs here. And
Okay.
you can go on and get, some things are already harmonized. You can get by country tables and things easily.
Cool. Okay.